So like any biomarker, there's a few things that needs to occur. And kind of going back to what I just said, a biomarker, it needs to be sensitive, needs to be specific, and needs to be easily measurable. And it needs to tell you actual good clinical information, essentially. So all those things. And it also needs to be, when I say easily attainable, it also comes down to cost as well. So in terms of actually the local health authorities being able to measure that and pay for it. So sensitive, yes. Say, for example, if we use CSF or if we use plasma NFL or these immune cell subsets, yes, they are sensitive. We can definitely see changes correlated to disease activity, but they're not necessarily specific. And I mean, you'll see that in a lot of the literature as well, that due to the nature of what neurofilament light chain actually is, where it's provides structural support to the axons, you see it in many different neurodegenerative conditions, whether it's Alzheimer's, say something like neurosarcoid, any inflammatory neurodegenerative condition, you're going to get an increase. And of course, the levels increase too as we age. So what we really need to do is make sure that we have standardized measurements for different age groups for people who have MS. That's one thing. And then if we decide to use CSF, well, that's a bit sticky because not many patients want to come in and get repeat lumbar punctures every clinic visit, which could be every 6 months or every year. So that's why we focus more on the plasma, which is easily accessible. It is much cheaper to measure. We have our high sensitivity ELISA now locally that we can use instead of sending samples away. But other challenges, like I said, would be, I guess, going forward, how do you, let's say, for example, if we don't have exact standardized measurements for plasma neurofilament light, which are up and coming, thankfully, then what kind of increase in the plasma neurofilament light is clinically meaningful for patients? Because like I said, we see these increases in studies that can demonstrate disease activity, can be linked to disease activity, but how much of an increase are we looking at where we would say as a clinician or an MS specialist, okay, I think you need to switch to DMT, or, we need to start a DMT, essentially in somebody. So that, tying that information, there still needs to be more work done yet to be able to say exactly how to use this, but I do see it potentially useful, like I said, for both prognosis and for DMT responsiveness.